Wednesday, February 26th. And we ran out of time. We ran out of time for Blue Cross Blue Shield on H266. So ask them to come back and care for. Thank you.
Well, thank you for accommodating my schedule. And I'm Sarah Teachout with Blue Cross and Blue Shield of Vermont.
Tom Weigler, the Chief Medical Officer of Blue Cross Blue Shield of Vermont.
And I'll operate the slide deck by I'll speak.
Sure. Do you have oh, there we go.
Yeah.
Okay. Slide. And I know a lot of this has been covered already. I think I'll skip down to the bottom part, which is that the 340B program has led to higher costs for people with commercial insurance. Well, there's not much oversight or transparency. And a lot of the savings may not actually reach the patients who need them. This is also something you may have seen already similar. The drug manufacturers provide the hospitals with the discounts. The hospitals provide the drugs to the patients, including those with commercial insurance. Although the hospitals bought the drugs at a discount off the average price, they actually charge the patients with commercial insurance the full markup price for the drug, and the hospital takes the profit for that. The drugs would typically be eligible for rebates for these commercial members, but 340B drugs are not actually eligible for rebates because the drug makers already gave the discount to the hospital. So again, commercial members end up paying more for 340B drugs, and a higher drug cost results in higher insurance premiums. Blue Cross Blue Shield of Vermont has data through our Blues plans that our members pay some of the highest prices for drugs in the hospital setting anywhere in the country for the exact same drugs. This is the RAND 5.0 data from 2022. It confirmed the information we already knew. Vermonters with commercial health insurance are paying significantly more for drugs when they receive them at a hospital with a 340B pharmacy. Sadly, we are actually the bar on the far right of this, paying 5 times the average sales price for drugs in Vermont.
The RAND data, not our data, but it confirms what we see.
I'm sorry, remind me what ASP is.
So average sales price, So yes, it'll come up a few times, average sales price.
And there are a lot of ways of determining the price, so there's WAC and there's ASP and there's a whole bunch, but we're just using ASP for this. I acknowledge there's other drug pricing numbers out there.
So there's a few reasons for this. The prices charged by hospitals are higher than the price for these drugs anywhere else. Blue Cross Vermont loses the manufacturer rebate when the drug is filled through the 340B pharmacy. And also, due to Vermont laws, we're unable to direct our members to lower cost sources of these drugs.
Is this one that we're on?
Oh, we're on this one now. What kind of prices are Vermonters paying for these drugs? The RAND report said that on average across the country, that the price is about 280% of ASP. As you saw on the prior slide, Vermont's average is 500% of ASP. And current markup on these 5 drugs through UVM Medical Center is over 1,000% of ASP, posing significant hardships for our members. All of these drugs are obtained through UVM Medical Center for far less than the ASP through the 340B program. The estimate is about 34% below ASP. And again, our members are paying over 1,000% of ASP.
Can I ask a question?
Yes.
Don't you negotiate with the hospital for the drug price?
Sure, that's
Is it in
actually
your contract negotiation?
so. There's a next slide that actually might explain it a little bit, which I'll go to that slide now. So this looks specifically at one of the medications noted, Remicade, the anti-inflammatory drug used for conditions like rheumatoid arthritis. The orange bar shows the average cost of Remicade to Blue Cross members over time. And the blue bar is actually the average sales price, the ASP of Remicade over time, which has been going down. So price going up, cost of Remicade, average sales price going down. Our members are now paying 1,112% of the average sales price for Remicade at UVM Medical Center. It really eats up out-of-pocket deductibles pretty quickly. The last bullet point there is that orange bar, the increase in price over time, 56% increase, that actually aligns with the Green Mountain Care Board approved rate increases for UVM Medical Center of 52%. So for example, if UVM Medical Center got a rate increase of 14% the following year, this drug price would likely be 14% higher, even if the price went down, if they increased rates across the board.
So, and I'll clarify a little more. The hospital decides its own charge master. So it's the price for the drugs, and we negotiate a discount off the charge master price, but we have to abide by the Green Mountain Care Board order, essentially. And so generally we're paying almost, or usually exactly what the Green Mountain Care Board approved for increases. And it's applied on all kinds of items, including drugs. And I guess the one other thing on the Remicade, to go back, is that there have been a lot of biosimilars that have come out on Remicade. Others know more about the drugs than I do, but that's why the price, the ASP price of Remicade, the blue bars, has dropped, because they're, once biosimilars come out onto the market, the price goes down, but our members are paying more.
Before we go deeper into this, can you go back? Well, I don't remember which slide it was, but the very start we were talking, and I don't need to slide for this, but so these are the prices when someone is prescribed this or gets it from a hospital on-site pharmacy. 340B pharmacy. But this drug is obviously prescribed and purchased in other pharmacies around Vermont. I use CVS. What's the price there, and how's it compare in various other settings? Because
You were going to ask that.
And why would anyone, if they knew the comparative pricing, choose, and is there a choice to not get your prescription at this cost at the UVM pharmacy?
Sure. So a lot of these drugs are actually infused medications. It's not your typical, wireless like they pick up at the pharmacy. But this is a comparison, exactly what you were talking about. These are two short charts showing the drugs noted on a prior slide. And the data is for UVM Medical Center, Dartmouth Community Physician's Office, Novella, which is actually an infusion site in South Burlington, and also through the Optum Medical Drug Pharmacy. As you can see, there's huge discrepancies in drug costs, as you said. Blue Cross Association data shows that for every one of our members per month, they pay an average of $32 more because of infused medications for their premiums. And the costs are increasing faster than other Blues plans. So compared to other Blues plans, we're a very high outlier for the costs of these drugs. And compared to other Blues plans, our costs are increasing faster. So those 2 points are made.
Right. And you're also asking about why a patient doesn't go somewhere else.
And you're saying on your plan and how much you pay, but also on Blue Cross, you're also paying to get these drugs, even non-infused drugs, like the same drug at a CVS and at UVM pharmacy is drastically different in cost sometimes. Is that true?
I have the data for these infused medications. I can certainly provide more information about other drugs that we purchase for members through the different sites. I don't have data on if you bought Advil at the UVM Medical Center pharmacy, is it a lot more expensive than CVS or even an antibiotic? I don't have that data with me, but I could certainly look into that.
Yeah, even if it's nothing super common, I was going to say antidepressants, but those are super common.
Yeah, an example.
Yeah, it would be helpful rather than something that's infused. I'm just curious if your plan is only paying for these. I don't think that's a very broad cross section or example, but maybe some other pharmacy types. How do they compare between those types of pharmacies?
Okay, we'll take that as a takeaway. as an example, an MRI is 3 to 4 times more expensive on average at UVM Medical Center than at a place like Open MRI down the street.
I see both of you. I just want to complete my thinking here really quickly. So if I'm a patient and I am seeing a provider at, say, UVM, and they say you need Remicade, I can either walk down to the pharmacy at ACC and I can get my Remicade there. Or unless it's an injectable that they have to do, but let's just. But they also, if UVM also has uses CVS as a contract pharmacy, if I left and got a drug there, which is a 340B drug, and CVS is a contracted pharmacy, would it be the same price?
Yes.
If I got it at CVS with a UVM provider prescribing it?
So
If I got it at the pharmacy?
yeah, so the example may be on the screen is that if your provider said you need Remicade for your rheumatoid arthritis and prescribe that, you could go to UVM and get the infusions for over $300 per infusion, or you could walk down the street and go to Novella in South Burlington and get them for $33.
Yeah, but that's who's doing the,
So those facilities are also obtaining the medications and billing Blue Cross for those through the members.
oh, okay.
So that, yeah,
Okay,
that
so
answers my question.
Mari and then Woody.
To what degree does the formulary setting by PBMs play into this? Especially if they're, for the Remicade example, if there are biosimilars, why choose Remicade when there's a lesser expensive biosimilar, and is the PBM directing traffic to the more expensive medication?
So an example is that we've just changed in January from Humira as kind of our first line to a biosimilar. And that's because of a lower price and also a better rebate. If that biosimilar is also obtained with 340B pricing, we wouldn't get a rebate on that because it's obtained through 340B.
Are you asking about who the prescribing? So
The formulary.
the formulary, so the formulary we use is Optum's formulary, the national preferred formulary, and they certainly put, on the tiered formulary, the drug that they get the best price for. It may or may not be the drug that the hospital gets the best price for, but the other thing that's happening is that the provider is deciding which drug is best for the patient. They could be getting prior auth for that drug so that they can get it in the hospital. And then the other thing that happened here is we weren't doing it, but a couple of years ago, the legislature passed a bill that banned white bagging. So that would have allowed us through Optum to send the drug or get it to the patient or to the hospital, and they could have then infused with the drug that we sourced at a lower price, and we're essentially prohibited from doing that. So we can't substitute now or direct the patient. There's a lot about directing the patient in that bill. And it's very hard for us.
Patients knew they could, and
If the
I
patient.
feel for that, if they knew they could go to another pharmacy and get it.
Sure. Yep.
Woody?
Yes, you have pricing for UVM and Dartmouth for these infused meds. Do you have price comparisons for other hospitals, or are we predominantly just talking about Dartmouth and UVM? How does that compare to other hospitals within Vermont?
So these are primarily things that are infused through an infusion center or UVM or Dartmouth,
So we're just talking about UVM.
mostly.
So that,
And medical offices can also, that's what's on the slide here, the community physician's office. Novella is an infusion center.
so is it accurate to say that Vermont hospitals are more than 5 times the average price of sales when you're only talking about UVM?
On these types of drugs, then it's,
Okay, so then how does it compare to other drugs? Do you have any slides on that as well? Regarding other hospitals in Vermont? I guess what I'm getting at is you have in one of your slides here that our hospitals are 5 times greater than the average sales price. Is that completely accurate for all our hospitals through Vermont?
I guess a different way to phrase it is on average, our members are, getting charged 5 times the average sales price through Vermont hospitals.
It is all hospitals. It's probably weighted more towards the
Yeah.
hospitals where people are getting all their drugs. But we certainly could look for the data. I think that the RAND study has data for every single hospital individually, so we could find that for you.
Yeah.
I'm just
happy to
curious,
provide that. Yeah.
Yes.
Just wondering whether how
They have-
accurate it
Yeah,
is.
they have data for every hospital.
Okay.
Do you have data on, FQHCs or Planned Parenthood as they compare to hospitals?
Yeah, I was asking Nancy for that, and I don't think we got it yet.
We haven't gotten that yet. We will certainly look for that.
That would be good to know. Thanks.
Good questions. This is just addressing that if our members actually got the same rebate deal at Dartmouth and UVM Medical Center as we do with Optum, as a whole, our members would have saved $12.6 million more in 2024. As was said, 100% of the 340B drugs are rejected for rebates. And this shows what we call the rebate rejection rate. This is the percentage of prescriptions where our members don't get their rebates, meaning they end up paying more. And as you can see, UVM Medical Center is really good at using the 340B program to bring in hospital revenue. And in the chart, the reject rate for UVM Medical Center is over 45%, whereas at 17% at Dartmouth and 5% through Optum.
Wendy,
Why?
right? I'm sorry, I didn't mean to.
So actually, it gets down to one of, or really our only ask, which is transparency. We don't know. We don't know what they pay. We don't know what they save. We don't know what those profits are. It's unclear which.
So if I, as a Blue Cross Blue Shield, if I went to Dartmouth, I wouldn't get rejected, or chances are, but if I go to UVM, my chances are 6 times higher that I will get.
So your health insurance company is getting rejected, not you, but.
Well, that's what I mean.
That's
That's what I mean. And well, in the end, then my premiums go higher. That's crazy.
Yes, that's the message. Your premiums go higher if more people are using UVM Medical Center than Dartmouth than they are today, then premiums go up.
It's also showing that they're really good at maximizing the revenue from 340B. That's what this is showing you. UVM Medical Center is the best, Dartmouth's next, but it makes sense because they're also academic medical centers, so they're using these drugs more than the other ones. But we're comparing them to Optum.
I have so many thoughts.
Me too.
I'm trying to like simplify this in my head a little bit. So, okay, the 340B program, it starts innocent. It's the young child. The point is that facilities, providers who provide services to more vulnerable populations are able to purchase their drugs from wholesalers at a discounted rate, which we won't even go into, how that might raise for the rest of us, but they get they get a discount from the wholesaler off the WAC. Then they take that and wasn't the intention that then they were able to be reimbursed the average sale price for that drug and they could keep that savings? And is what you're presenting to us essentially that they're just raising the price, the reimbursement that they get exponentially and then keeping all the savings as opposed to the intent, which was if the average sales price is like, I don't know, in one of your cases, $34 or something, $33.50, that they might have purchased that for $5 and they get to keep that 23, whereas somebody who's not a 340B would purchase it for say $15 and only get to keep 15 of it. And
So I don't think
I
there's a
guess I'm
limit
not,
on that.
I guess I'm not wrapping my, I think the thing I'm struggling with is the assumption that I made that everyone was paying the same, that say Blue Cross Blue Shield or whoever was paying the same price for whether you're a 340B or not a 340B, and that they just got to save a little bit. They just got to save their discount on the WAC. And are you saying that that's not appears to be what's happening? Which is why it would be really curious to see if we could figure out between FQHCs and other qualified things. And Topper, did you have a question? I thought I saw your.
No.
Oh, okay. All right. I'm sorry. Thank you. I guess I didn't
I know what your
I
question
guess I didn't have a question in there. It was more,
There is supposed to be a delta where they make some profit. Ideally, I think the intent is that all that profit goes back to free care, or to, underserved populations. But we don't have any transparency into that. And one of the points is that it really increases the burden for commercial members because of this delta and because of the lack of rebates. Which is, the key takeaways are Vermonters are paying more, rebates are not available for these 340B drugs for commercial members. Hospitals get the discounts on the drugs through 340B, but the commercial members pay full price. Members with high deductible plans end up paying more, and often these prices are exorbitant. Blue Cross is unable to use existing contracts to get our members the lower pricing they deserve because of 340B. And since Blue Cross members pay full price instead of the discount, overall insurance costs go up, leading to higher premiums for everyone. The intent is this discussion is not to do away with the 340B program, but to really put forward some transparency proposals that Sarah's going to talk about.
Right.
Sorry.
So I have read H202 that you're going to talk about. Appreciate the transparency in there. This is more specific. This would require, I have to put on my glasses, sorry. This would require any participant in the 340B program to report the price that they actually pay, the discount price they're paying to acquire the drug from the drug manufacturer. Also require that they disclose the amount charged to the insurance company for each medications expense, not in aggregate. Require them to report on the utilization of the financial margins generated. So I think this is what you heard that the FQHCs are doing, but we really want it to be broadly across everyone benefiting from the 340B revenue in the system. So including patient care, community health programs, administrative services, and hospital operations. And then report the percentage of the 340B drug margin reinvested into programs, specifically benefiting underserved and low-income populations. So this is all information that you would get through transparency. The real difference between what I'm proposing here and what's in H202 is this is specific to the drugs, not aggregate data. I will tell you that health insurers already report very specific drug data to the AG's office and the Green Mountain Care Board. So we're required to do drug by drug specific reporting. We think that these programs should have to as well.
You have the technical capacity with your computer systems to do that.
We do. That's true. I think some of these hospitals do too.
Is it not shareable so we could see what you're talking about?
Sure,
Not
there's,
right now.
yeah. There's data that the Green Mountain Care Board posts every year that we report to them, and the other health insurance companies are required. They're the drugs that we spend the most on every year, that have had the highest price increases every year, that type of thing. And we think you should be evaluating the impacts of this program on patients, hospital budgets, and commercial health insurance premiums before making additional changes that could have negative consequences. And we think that these findings should be shared broadly with the legislature, regulators, and the public. So I just summarized, this is what I'm proposing here is more detailed than what you have in the bill that's on your wall. So, thank you for listening to us. I think you've sent us home with some homework and additional questions that I'll do my best to try and answer, because I know you're considering these bills right away.
It sounds like we're
Thank you so much.
two of you tomorrow.
Yeah, I think we're gonna look at 202 tomorrow, specifically the pieces in that round. Thank you.
Yeah,
Thank you for having us.
Yeah. Let's give it back to budget. The ones, Brian, do you have your? I get a little one here.
Yeah, I'm summarizing it right now on a piece of paper like you
Do
asked.
we have a tally yet? I'm sorry, I sort of, maybe Jen can, maybe walk us through a little language that she's already prepared?
Are you okay with everything that was in it?
Yeah, well, just walk us through what's in it and see if everyone's okay. Brian's the only one messing up.
And I'm writing it down as we speak.
No, Jen's gonna come up.
Yeah, like that.
Just the Hold the battery.
So it's just below running.
Okay,
They pull it, or you know, something else.
so Jen has been working on
Understand.
language and she's gonna walk us through it. Okay. We're still live also, please.
Right. Good afternoon again. Jen Carvey from the Office of Legislative Counsel. Some of this, all right. This up. So yes, as the chair said, I worked on some language based on some of the conversation you had in here yesterday and proposals you've gotten, and I'm not sure where you are with them, so we'll look at language and make changes. The first is on the community outreach program. And this is language you had asked me to work with Representative Chena and Representative Houghton on. So this would say that as part of its fiscal year 2026 budget adjustment proposal, the Department of Mental Health must provide information to this committee, the Appropriations Committee, and Senate Health and Welfare regarding ways to sustain existing community-based mental health outreach efforts, including continued funding for the Howard Center's community outreach program, ways to expand low barrier community-based mental health services in rural underserved areas of Vermont, to engage individuals in crisis with outreach support and connection to services, and ways to support integration of low barrier community-based mental health services into Vermont's system of care, along with services such as the 988 Suicide and Crisis Lifeline, local crisis response teams, mental health urgent care recovery centers, and other peer-based services.
So this is in response to CMH's proposal to eliminate funding for those two programs. And I think we had agreed this morning that we are going to request that they not be eliminated, that they continue at least for another year until they can come back with this. Is everybody in agreement with this and supports the language? Okay, we will send that along to appropriations.
Next is the FQHCs of payment methodology, and this directs the Department of Vermont Health Access to collaborate with representatives of the FQHCs to develop a mutually agreeable Medicaid payment methodology for the FQHCs that complies with federal requirements and adequately reimburses the FQHCs for providing care to Vermont Medicaid beneficiaries. It would be due by October 1st and reported to the Joint Fiscal Committee, the Health Reform Oversight Committee, this committee, and Senate Health and Welfare. This is sort of similar to, but less specific than some language passed 2 years ago by this committee at the time, that was having, again, trying to get them to work on a mutually agreeable methodology, although more specific there.
And I think this is, we've heard testimony that they have been in talks for many, many, many years. So does everyone understand that and have any questions about it? Everybody in favor of submitting that language as well? Leslie?
The episodic design, that's not addressed here, that's federal, just so I understand that.
This addresses coming up with the, I'm so sorry, the rate, the
Encounter rate.
encounter rate.
And the design of the, but that's what I'm wondering, does that include that?
So American Loan, but by state, so there's the minimum that is set, the methodology is set in federal statute. But the federal statute also allows states, needs to work with FQHCs to figure out a payment methodology that works for both. It just has to be greater than federal requirement.
So you could address the episodic problem.
Yeah.
That's all I want to know, thank you.
Okay,
Okay.
okay, great.
And then the third piece that's in here is the various position requests for the board. This was just based on what they had provided to you yesterday or a few days ago, so I don't know if there have been changes since then. The way this is drafted, it's in 3 parts. So first is establishing 3 new permanent classified positions. The establishment is authorized at the board in fiscal year 2026. Those positions will be transferred and converted from existing vacant positions in the executive branch. And these positions are 1 health systems financial principal analyst, 1 health systems access principal analyst, and 1 health systems quality project manager. The second piece says if the state moves forward with implementation of the AHEAD model through CMS in fiscal year 2026, the establishment of the following 2 new permanent classified positions is authorized at the board beginning in the second quarter of fiscal year 2026. I think the date in their material was September 30th, so October 1st is the first day of the second quarter. These positions, again, would be transferred and converted from existing vacant positions in the executive branch. And that is 1 director global budget and 1 procurement manager. And then it has the funding. It would appropriate $135,000 to the board in fiscal year 2026 from the general fund as base funding and $202,500 from the Green Mountain Care Board Build Back Regulatory Fund. And that combined amount would be for the positions. And then finally in C, we would have the establishment of 2 new classified 12-month limited service positions, data and reporting coordinator authorized at the board in FY26. And for those in FY26, $80,000 was appropriated from the general fund as one-time funding and $120,000 from the Green Mountain Care Board Build Back Regulatory Fund for those limited service positions.
Right,
Yeah, I have a question about this that I don't expect answered today, but I wanted to ask now.
Sure.
Well, I'll just ask. Is there gonna be time for us to talk later about what the Green Mountain Care Board plans to do or could be doing while we're waiting to see what happens with the head. And the reason I ask is because this is about, there's some positions that are going to immediately go into, well, in July, I guess, right? Go into effect. And then others that will come into effect if we go into a head. But I'm wondering, I think the language is fine, but I'm wondering if we can come back to this later with Green Mountain Care Board and just talk more about being proactive versus reactive, being ready for a head, but also thinking about what we're going to do without it, if that makes sense. And I just wanted to know if we were going to come back to that at some point, or if we could, when there's more time to get into details.
Yeah.
Okay, we don't have to do it now. I just want to put it out there now, because reading this, and when I was reviewing everything earlier, I was thinking a lot about, what could we do to be more prepared versus just reactive? That's all.
I think that's one of the reasons that they've requested the 5 positions.
Yeah.
Is because they need 5 positions to prepare to get ahead to. I
To get into a head,
to get,
to implement a head.
well, to start thinking about, and I
Yeah.
mean, because they have been very honest that if we go ahead with a head, it's going to require many more positions.
Yes.
As it probably should. 'Cause
Yeah, and I
Make
guess
sure.
my question is then, and we can talk about it later, can they also be looking at the alternative? So if we don't get into a head, what are we gonna do? You know,
I think a lot of that is also happening downstairs
Yes.
Yeah.
downstairs.
instead of health.
Oh, I'm sorry, we're gonna get a bill or something.
Yes.
Okay, fine.
Yeah.
Moving on, I just wanted to put it out there now while we were looking at this.
Everyone okay with this language? Yes, go ahead.
Good job.
Yeah.
I just want to bring up one question. Let's say the worst of all happens and we do not, a head doesn't continue. What happens to the positions that we're talking about here?
We had talked this morning about language that it would be then put into, it would budget adjustment.
Right.
Yeah.
It
Does
would
that
be
cover it?
unspent.
Is that in there?
Well, so the language here is on those 2 positions is conditional on the state moving forward with the ahead model, and the positions are created in the, or are authorized beginning in the second quarter of fiscal year 2026. And this funding is for those positions. If those positions are not created because the state doesn't move forward with a head, that money will remain in the general fund for reallocation and budget adjustment.
What about the other ones?
Well, those are getting, I don't believe those were connected specifically to a head. I think this is to address,
3 full-time?
this is to address needs at the staffing needs at the board.
To take them out of pool, right?
This could take them from.
Makes,
Right, I mean, this pool idea is the same thing as transferring and converting from existing vacant positions, but this is doing it legislatively as opposed to the board asking for something that they may or may not get. So this gives them the 3 positions that they have, 3 permanent positions that they have asked you for, regardless of what happens with anything else. The 2 positions for a head are contingent on the state moving forward with a head.
so the other three don't deal with that at all.
They may be part of their job duties if they're hired and a head happens, but they're needed at the board with the board's existing workload.
Everybody in favor of sending this language as well, appropriations?
I think it's great.
Yeah.
Okay, I think it's great too. It's
Make
smart.
more hand approval.
Okay, I'm never sure if it's a question. Okay, so everybody's in agreement.
Yeah.
So that's the language we have. Let's see, thank you. Darren.
Are you expecting more language
Um,
needs? I mean, I'll stay, but I'm just curious if I should be working on.
I think, if we could have just sort of a very simple statement regarding the first one we talked about the community health outreach and mobile crisis and all of that. Just to be able to advise appropriations that we'd like to keep these 2 programs for 1 more year. And And that's why we're then giving the language.
Okay, yes, I think I need to understand the format that you're presenting everything in generally, but we can talk about that.
Okay. And if I recall, actually, when we done our spreadsheet and given to appropriations before, this note section was what we used to tell them what we're using it here for the purposes of reminding us exactly what it is. But generally, we would use this column for, here's what we'd like, here's what we're recommending on it. As opposed to, yeah, so we'll do that. Okay, thank you.
Working.
Oh, okay. How much more time do you need, do you think? 10 minutes?
At least.
Should we take a break or is it gonna
Okay,
disperse?
we'll have to take a break.
Sorry, I just started.
Okay.